So we have a minimal safety net in this state, but the truth of the matter is that safety net is pretty porous, and it's still based upon whether or not people feel like, even at a health center or a free health center, can they afford a $15 visit? Not everybody can. We have a free clinic here in Pocatello. There's one in Twin Falls. There's one in Boise. I think there's one up north someplace, but I don't remember. Pardon me? Lewiston has one. But, you know, this is like the kid putting a finger in the dike. You can put your finger in the dike, and it helps for a few people that you got the finger in the dike, but it's totally insufficient to take care of the care. So let's talk about the Affordable Care Act a little bit. I got to tell you that I'm not one that believes it was the worst thing that ever happened to the world, mostly because I've spent a whole career working around people who have no health insurance, and a lot of that's not their fault, and trying to figure out how we do it. The other thing that's interesting to me is that the original, one of the original designers of exactly what we got was not Barack Obama, it was Richard Nixon and the Heritage Foundation. Anyway, if you go back far enough,
even Theodore Roosevelt was.
Yeah, if you get into how do you take care of folks. So the Affordable Care Act had a couple things in place. First, it did say, okay, everybody's got to play. And there's a mandate, an employer mandate with penalties. But the truth is, on that, is the only way to make sure everyone is covered is everybody's got to be in the game. And it's just a matter of when you get in the game. Waiting until you need the insurance is a little too late in the game. It's sort of like buying your retirement plan. The sooner you get in the game and we can all help each other out, the better off we all are. So the Affordable Care Act offered this. It really had a couple big parts of it. One is it would subsidize private health insurance for people who had income between 100 and 400% of the poverty level, and small businesses through the state or federal health insurance exchanges. So that was one piece of it. The other piece was the expectation that Medicaid would cover folks below 138% of the poverty level. So there would be sort of a two-part process. There was another piece of this exchange, just for your information. We talk about county and state money on medical indigency. To get people from when the act was passed until January of 2014, the exchange created a little plan called the Pre-Existing Condition Insurance Plan. And they created this pool of money to say, okay, if someone was uninsured, had a serious health condition, there was a way to get subsidized health insurance to help those folks get the care they needed. The counties, this is sort of the interesting dialectic we have, because the counties who were not happy with the Affordable Care Act discovered it was less expensive for them to go out and pay a year's worth of premium to buy someone a pre-existing condition insurance plan and let the insurance plan pay the hospitals and the doctors for the condition that had to be treated. So that plan got used up, and it's actually been used so well around the country that it's now they're not taking any new applications. But that existed. So it was an interesting little flip. So we had really, the Affordable Care Act has lots of other pieces to it. I mean, a couple thousand pages. There's pieces around changing the way providers get paid, looking at different models of care. But we'll talk a little bit about these. And in our state, essentially what happened was that when this was passed, lawsuits were filed originally about the Affordable Care Act, was going to the Supreme Court, and everyone figured that the Medicaid, the requirement that states expand their Medicaid to cover people to 130, everybody thought that was just a done deal. That was required under the Affordable Care Act. What people argued about that went to the Supreme Court was really the individual mandate and having a health insurance exchange. So the Idaho legislature in 2012 made the decision, let's wait and see what happens with the election in the Supreme Court. Probably almost everybody who looked at what the Supreme Court was going to do said, oh, Medicaid's going to stay in place, but the individual mandate may be the one that might go out the door. Well, the Supreme Court surprised everybody in June of last year and said, guess what? The individual mandate stays in place, so you better keep going on that. But states, you now have an option to do Medicaid or not to do Medicaid. So it took everyone by surprise, and that was like June of 2012. So they said, look, you can design, you can do a Medicaid package, you can do a new package. You don't have to do, thank you, Kathy, very much. You don't have to do what you've been doing with Medicaid all along. And to really sweeten the pot, we're going to pay all of the cost of care for the first couple of years. We're going to pay 100% for the first 3 years starting in January of 2014. And it'll gradually lower to 90% by 2020, but it doesn't go from 100 to 90. It goes from like 100 to 97 to 96 to 95. So it's a gradual slope. But you have to cover everybody. You can't just say, well, we want to do it, but we only want to cover people to 50% of the poverty level. We want to cover the whole match. So that was what people had to do. What happened in June, the Supreme Court said, guess what? You get to choose. The governor, and actually this was unusual for a Republican governor in this country because many Republican governors said, we're not going to do anything. This governor said, well, okay, I'll have a work group look at Medicaid. I'll also have a work group look at the health insurance exchange. We won't get into that one tonight. But he said, let's go ahead and do it. He appointed a work group. I was asked to be on that work group to do the evaluation. Part of what happened with this state, there was a huge amount of effort that had been built over a 2 or 3 year period around a health insurance exchange. That passed in the Idaho legislature this year. The Medicaid expansion work group had given the governor a recommendation in December to move forward. The feds created new rules in January. We had to reconvene, and so the final recommendation didn't get to the governor and the legislators until March. We'll talk about the incentive to do it right, but by March, they had fought the fight over the health insurance exchange. They were fighting the fight over the education budget. It was starting to get spring, and the farmers and the legislators were ready to go back and plant. You're shaking your head. And they just didn't have the energy to do anything else. From a healthcare perspective, they also did a couple good things. They expanded the number of medical school seats for WAMI, which was a good thing, and they expanded the funding for residency programs for family medicine and internal medicine. So there were some good things. My view was not quite enough, but there were some good things. The work group that I was on met 3 times. We got a lot of reports for consultants about who are the people that would be impacted by this, what would the costs be. The Hospital Association worked with the University of Idaho to do an economic expansion study to take a look at what would be the economic impact of bringing all of this new revenue into the state. So we got a lot of information. The work group had 15 folks, hospitals, consumers, legislators, both Republican and Democrat, met 3 times, looked at all of the data. And in December, basically, the work group said to the governor, this is the right thing to do. We universally supported it. There was a lot of talk about what the plan would be and how that might have to differ a little bit from a traditional Medicaid plan. But the sense was, this just makes sense. So the governor got that in the middle of December. One of the issues about all of this working is some things can happen very fast if there's a lot of unanimous political support, and some things happen very slow or sometimes not at all if you don't have the support and you've got to figure out how to build it. And so this recommendation went to the governor in early December, which is actually late because most of the time budgets get set oftentimes in October and November. And so this was way past. State agencies sometimes have to submit their budget recommendations sometimes in July and August. And so there's just the lag was huge. But we said, look, do it. And this was a unanimous recommendation from the work group. There were no dissenters. We also talked a little bit about what the benefit design would be. And we talked about trying to figure out if you're going to expand, can you do something that people talk about having skin in the game? And can people own? It's not just a benefit, but people share in the responsibility for their care and maybe share a little bit in the premiums. You've got to be careful with that because if you're below 100% of the poverty level, you don't have much to share. You're already sharing a lot because you're taking a $9 an hour or $7 an hour job. So it's not like you have $30 or $40 a month that you can invest in health care. You won't do it. And then look at the service system, because in health care, we have a service system in health care that's designed around the more you do, the more you get paid. Doesn't matter how well you keep you, but the health care service system is designed around volumes and visits. And as long as it's designed around there, there's no incentive. And actually, I used to joke when I ran a health center, the best thing for a community health center was a good flu season. Everybody got sick, had to come in. You know, that's sort of a perverse way. I mean, you don't get paid for keeping people well. You get paid for treating people who are sick, and the sicker the better. So the service delivery system is expensive. We have the most expensive health care in the world, and we now are ranked 17th out of 17 economically developed countries in average lifespan. That's right. So we spend a whole lot of money, and we die quicker. So that makes just a lot of intuitive sense to me. But that's who we are, and proud of it. Okay, so let's talk about what's happening. So, in January during the State of the State address, the governor said basically, I'm not going to talk about Medicaid this year, but he wanted health and welfare to look at a payment model or insurance model that might work and would be sellable in the Idaho political climate. We also got new information from the Department of Health and Human Services about who would be eligible under the new program versus who would be automatically fit into the existing program. In November, we had data that said there would be more people that would fall into the existing program than existed. So we thought that bump would be bigger. The feds changed the rules and said, no, your numbers are going to stay the same. Everybody falls into the new category. So we were reconvened in March of this year. So March 18th, we reconvene and meet, and the legislators are getting out a couple weeks after that. So there's really, by the time we met the second time around, it was pretty well out of time. Representative Lurcher from Idaho Falls introduced a bill in the last week of this. Actually, I thought it was going to be the last 3 days of the session, but it took an extra week for them to decide. But by the time he introduced the bill, it was one of those times you introduce a bill to make people aware that it's out there. He had been asked to sit on the bill until they got the health insurance exchange passed. He did. He was a county commissioner. You can't talk to a county commissioner in the state who likes the county medical indigency, state catastrophic fund. It just doesn't work. But it's what we have. So we looked at some things that were done in Indiana. So as we looked at a plan, and this still takes federal approval, wanted to put in some things where you could have some limited copay for office visits and some limited contribution for people, sort of a monthly premium that would be affordable. But there would also be a way to create a health reimbursement account. And so if someone did their preventive health visits or did their immunizations, money would flow into that account, which would make their cost almost come to zero. So there was a way to say, yeah, you have something, but if you get good health care and you get your immunizations and you get your pneumonia vaccine and you're doing your women's health check and you're doing some colorectal screenings and all those kind of things, you can actually fill your pot. And so there's been a lot of work trying to figure out how to do that, try to build in some incentives for smoking cessation or weight loss. And if you can do those things, you get money put in the pot. So you try to make it set up, because there's a lot of research that shows that if you have the Medicaid expansion and you have the insurances offered through the exchange, people will flow back and forth. Some people will go from part-time to full-time, which would cause them to lose Medicaid eligibility but make them eligible for some of the subsidies within the exchange. Some people would be in the exchange and then might lose hours and fall back into Medicaid. And you wanted something that would sort of be seamless so that they wouldn't lose who their medical provider was and how all of that would come together.